Welcome back to the deep dive. Today, we are taking a step away from the purely mechanical side of healthcare.
Yeah, we are.
We are putting down the stethoscope, stepping away from the IV pumps and, the cardiac monitors, and we are walking into a space that I think it terrifies a lot of students more than a complex math calculation ever could.
It's a space where there are no clear-cut algorithms, that's for sure. I mean, you can't just follow a flow chart.
Exactly.
We are heading into the nuanced, sometimes chaotic, but incredibly vital world of psychiatric nursing.
Specifically, we are doing a deep dive into a really comprehensive lecture on therapeutic communication and the therapeutic relationship. Now, I know who is listening to this. You are likely a nursing student. You are probably drowning in pharmacology flashcards right now. You are memorizing the side effects of lithium and the dietary restrictions for MAOIs.
Which are important, don't get me wrong. Please learn those.
Absolutely, 100%. Lecture makes a really bold claim that serves as our mission for this deep dive. She essentially argues that in the context of psychiatric care, the medication cart is secondary.
It's a supportive tool, not the main event.
Right. The most powerful tool you have, the one that actually drives the healing, is you. It's your voice, your presence, and your ability to connect.
It's the soft skills that are actually the hardest clinical interventions to master. And I love that we are calling them interventions because that is what they are.
Yeah.
When you talk to a patient in distress, you aren't just chatting. You're not just passing the time. You are administering a therapeutic agent just as potent as any pill.
That is the so what for today. I mean, why should you, as a busy student, care about communication theory?
Right, with everything else on your plate.
Because poor communication isn't just socially awkward. It leads to poor clinical outcomes. It's a safety issue.
Exactly. The research highlighted in our source material is crystal clear on this. Effective communication enhances medication adherence. Just think about it for a second. If a patient doesn't trust you, if they think you don't see them as a person, why on earth would they take the pill you're handing them?
They're not going to. They're going to cheek it or just refuse it outright.
Of course. And good communication, it reduces relapse rates, it improves patient satisfaction, which is a huge metric now. We are moving from a model of doing things to the patient to doing things with the patient.
And to do that, you have to build something. You have to build what is called the therapeutic alliance. So let's start there. Let's lay the groundwork. If we are building this alliance, who is the architect?
The architect is undoubtedly Hildegard Peplau. You absolutely cannot pass a psych nursing exam without knowing her name. She is effectively the mother of psychiatric nursing theory.
Before Peplau, nursing was very custodial, right? It was about keeping people clean and fed and safe, but not much more.
Right. It was functional. It was about managing the environment. Peplau came along in the mid-20th century and she revolutionized the entire field with her interpersonal theory.
And what was the core of that theory?
She argued that the relationship itself is the therapy. It's a transitional model where healing occurs within the interaction between the nurse and the patient. It's not something you do to them, it's something you create with them.
And she broke this relationship down into very specific phases. This isn't just, hanging out and being nice.
Yeah.
It has a structure. It has a purpose.
A very clear structure.
And let's walk through these phases because I think they provide a really good roadmap for a student walking onto a psych unit for the first time, feeling totally overwhelmed. The first phase is the orientation phase.
This is the beginning. And honestly, it's the most critical because if this part fails, nothing else happens. The whole thing collapses.
No pressure.
No pressure at all. This is where you establish what the source calls the contract.
Now, when you say contract, are we talking about a legal document, something you sign?
Rarely. Very rarely. It's almost always a verbal or even an implied agreement. The orientation phase is about setting the stage. You are introducing yourself, you are explaining your role, and you are establishing the parameters of their relationship.
So it's like, hi, I'm your nurse. My name is X. I will be here until 7 p.m. And during our time together, we're going to work on your anxiety management. Is that it?
That's a perfect start. You're defining the who, the when, and the what. You're creating predictability in what is, for the patient, a very unpredictable and frightening environment.
The source material uses a really poetic phrase here that I loved. It talks about establishing nearness.
I love that phrasing too, establishing nearness. It's not about physical proximity. It's about psychological proximity.
Yeah.
It's about creating a sense of safety.
How do you do that? How do you establish nearness?
You do it by being consistent, by being honest, By answering questions directly, you're orienting the patient not just to the physical environment, but to you as a person. You have to convince the patient through your actions and your words that you have a safe harbor in their storm.
So in this phase, you're basically making a promise. I am here, I am trustworthy, and I am focused on you.
That's the implicit contract, yes. You're building the foundation of trust brick by brick.
Okay, so we've broken the ice, we've established nearness, the patient knows who we are and what we're about. Then we move into the second phase, identification.
This is a subtle but incredibly powerful shift. In the orientation phase, you are just a staff member. You're a person in scrubs. In the identification phase, the patient begins to identify you specifically as a resource.
So it's a move from the general to the specific.
Precisely. They stop seeing you as a generic uniform and start seeing you as a unique individual who can help them with their unique problems. It's when they might say, "Can I talk to you later?" instead of just, "Can I talk to a nurse?"
The lecture notes mention that the patient feels unique here. Why is that so important?
Yes. Because in a hospital system, it is so easy to feel like a number or just a diagnosis. I'm the bipolar in room 4. I'm the schizophrenic in room 6. It's dehumanizing.
Right.
In the identification phase, the patient has this moment where they realize, wait, this nurse understands me. They're not just reading my chart. They get where I'm coming from. That is the moment the real walls start to come down. They feel seen.
And that feeling of being seen, of being unique, that allows them to move into the third phase. And I have to pause here because the name of this phase is, well, in any other context, it's a terrible word.
Oh, I know.
Exploitation.
Every single student pauses at this one. They get a look of horror on their face. Wait, I'm supposed to exploit the patient.
Yeah. Am I about to lose my license? Let's unpack that so no one calls the ethics board. What does Peplau mean by exploitation?
In Peplau's theory, exploitation is a positive term. It means the patient is making full use of or exploiting all the services being offered. Think of it like a miner exploiting a rich vein of gold.
Okay, that's a much better analogy.
The patient is finally engaged enough and feels safe enough to use the therapy, to use the medication as prescribed, to use the nurse's expertise, to use all the tools available to get better.
So if a patient is suddenly asking a ton of questions, if they are attending every group session, if they are really leaning on staff for support, that's not them being needy or demanding.
No, that is them entering the exploitation phase. That is a huge clinical success. It's the working phase of the relationship. It's when they're actively digging in and doing the hard work.
And the lecture says this covers the physical, psychological, and spiritual dimensions of care.
Yes, they're making full use of everything. They might be working with the psychiatrist on meds, with you on coping skills, and with the chaplain on spiritual distress. They are exploiting the entire system for their own healing.
Which is what we want.
It's exactly what we want.
Yeah, and finally, because this is a transitional model, it has to end. We have the resolution phase.
Right. The goal is hopefully achieved. The patient is being discharged. The relationship ends.
Yeah.
And this part is crucial too. A good termination is just as important as a good orientation. You have to prepare the patient for the end of the relationship. You review the goals they've met, you discuss the skills they've learned, and you help them transition to their next source of support, whether that's an outpatient therapist or family. You don't just say bye and disappear.
Because that can feel like abandonment.
It can completely undo all the good work you've done. A planned therapeutic ending reinforces their independence.
This whole structure brings up a massive point of confusion for students, and the source material is really clear about it. The difference between a therapeutic relationship and a social relationship.
Oh, this is the biggest tripwire.
Because if I'm sitting there listening to a patient and we're connecting, and maybe we're even laughing, it feels like friendship. It really does.
It feels like it, but it cannot be friendship. The source material is adamant about this. The nurse-patient relationship is distinct for one primary reason. It is goal-oriented.
What's the litmus test here? How does a student on the floor, in the moment, know if they've crossed the line from therapeutic to social?
The test is to ask yourself, in that moment, whose needs are being met right now?
Okay.
In a social friendship, it's mutual. It's reciprocal. I tell you about my bad breakup, you tell me about yours. We support each other. Our needs are both being met. In a therapeutic alliance, the focus is 100% always on the patient's needs.
So the moment I start talking about my own life, my own problems, my own bad day.
You have broken the alliance. You have shifted the burden onto the patient to now take care of your feelings. And they are not there for that. They don't have the capacity for that.
That's a really clear distinction.
The source lists the core qualities of the alliance: empathy, understanding, awareness, and empowerment. Not one of those is about the nurse's needs.
Let's touch on empowerment. That seems key.
Yeah.
The notes mention promoting autonomy.
This is the absolute difference between being a friend and being a professional. A friend might give you advice. A friend might say, oh, you should totally leave your husband. He's a jerk.
Which feels helpful.
It feels helpful, but it's not. A therapeutic nurse says, it sounds like you're unhappy in your marriage. Let's look at your options so you can decide what is best for you. It's about shared decision-making. We want the patient to be independent, not dependent on us.
That's a hard habit to break. As nurses, we are trained to fix things. We all want to give advice.
We do, but advice giving creates dependency. It's a short-term fix. If I fix it for you today, what happens when you have a problem next week and I'm not there? I haven't taught you anything.
You're teaching them to fish, not just giving them the fish.
Precisely. And the hook you use to catch that fish, it's empathy. That's the tool that gets them to engage.
Empathy. Okay, this is the buzzword of the century. Everyone says be empathetic. But Dr. Butler's lecture breaks this down using a Venn diagram of the 3 types of empathy, which I found incredibly helpful. It turns a fluffy, abstract concept into a technical skill.
It does. It really operationalizes it. It separates the head from the heart and then shows how to put them back together.
Let's start with circle 1 of the diagram, cognitive empathy.
This is the head circle. The source defines it as the ability to rationally understand another person's feelings and thoughts. It's the I can put myself in your shoes perspective.
So it's logical. It's an intellectual exercise.
Uh-huh.
I see you're crying. I know you just lost your job. Therefore, I can deduce that you are sad.
Right. You understand it intellectually, you can see the cause and effect, and this is a very important skill. But here's the catch. You can have very high cognitive empathy and be completely cold.
Oh, so?
Well, the classic example is a con artist. A good con artist has exceptionally high cognitive empathy. They know exactly how you feel, what you want, what you fear, so they can manipulate you. It's understanding without caring.
Yikes. Okay, so that's clearly not enough for a therapeutic relationship. We need more than that. So let's add circle 2, affective empathy.
This is the heart circle. This is I feel with you. This is when the mirror neurons in your brain actually fire. You see someone suffering, and you physically and emotionally feel that distress yourself. It's a shared emotional experience.
This is the student nurse who sees a patient crying about a loss and bursts into tears right alongside them.
Exactly. And while that is a beautiful, deeply human response, in a clinical setting, it can be a disaster.
Why? It seems so caring.
Because if I am drowning in a hole and you jump in the hole to hold my hand and cry with me, now we are both stuck in the hole. You can't help me get out.
You can't be the lifeguard if you're drowning, too.
Correct. Pure affective empathy, unchecked, is the fastest road to burnout. You're carrying everyone's pain home with you every single night. You can't sustain that.
So we need the sweet spot, the place where the circles overlap. Circle 3, compassionate empathy.
This is the goal. This is the therapeutic sweet spot. The source defines it as, I understand what you feel, that's cognitive, and I want to help. It combines the intellectual understanding with the emotional connection, but it adds a crucial third component, an action component.
It's the action part that makes it therapeutic. I see your pain, I feel for you, but I am staying on the edge of the hole. And now I am going to use my skills and my rope to help you navigate your way out.
Yes, that's the perfect metaphor. You're connected, but you're not enmeshed. You maintain your professional objectivity and your toolkit.
And we need to distinguish all of this from sympathy.
Oh, absolutely. Sympathy is the bad word in this lecture, and for good reason.
Why is it so bad? It sounds nice to be sympathetic.
Sympathy is I feel for you. It's looking down from a position of stability and saying, oh, you poor thing. It creates distance. It creates a power imbalance. There's an element of pity in sympathy.
And nobody wants to be pitied.
No, they want to be understood. Therapeutic presence is about validating their experience. This must be so hard, without losing your professional boundaries. Empathy is connection. Sympathy is separation.
Validating without losing boundaries. I think that should be tattooed on every psych nurse's arm.
It would save a lot of trouble, that's for sure.
Okay, so we have the mindset. We are aiming for compassionate empathy. Now we need the actual toolkit. How do we transmit this empathy from our brain to the patient's brain? The source introduces the communication loop.
This is Communication 101, but in a psych ward, the stakes are just so much higher. You have the sender, that's you, the nurse. You encode a message, you put an idea into words, and you send it.
It's time for group therapy. A simple, clear message.
Right. Seems simple. Then the receiver, the patient, gets that message, but they have to decode it. And this is where the wheels fall off.
Because their decoder might be broken, or at least seriously skewed.
Exactly. The source notes that decoding involves interpreting feelings and connotations, not just literal words. If a patient is paranoid or actively hallucinating or in the depths of a major depression, their internal filter is completely distorted.
So I say it's time for group therapy, and their decoder translates that as she wants to get rid of me, she's kicking me out of my room, she hates me.
Precisely. Or they're taking me to group therapy to poison me. Or group therapy is a test, and if I fail, they'll never let me leave. The potential for misinterpretation is almost infinite.
Which is why the final part of the loop, the feedback part, is so vital.
It's non-negotiable. You have to check the decoding. You have to close the loop. You can't just send the message and walk away.
So how do you do that?
You ask for it.
Yeah.
What are your thoughts about going to group today? Or you clarify your intent. I'm asking you to go to group because I think it will help you feel less isolated, and I've seen how it helps others. You make the implicit explicit.
Now, before we even get to the words, the source emphasizes the silent majority of communication, the nonverbal cues.
This is huge. The old saying is that something like 90% of communication is nonverbal. The number isn't important, but the principle is. Your eye contact, your body posture, your tone of voice, these are screaming messages at the patient long before you open your mouth.
So if I walk in with my arms crossed, looking at my watch,
You've already sent the message. I'm busy, I'm closed off, and you are an inconvenience. The patient has decoded that, and it doesn't matter what you say next.
there's one nonverbal technique listed in the lecture that is absolutely terrifying for most students to even think about.
I know which one you mean.
Silence.
The dreaded silence. It's the most powerful and the most underused tool we have.
Why is it so hard? Why do we hate it so much?
Because socially, silence means failure. It means the conversation has died. It means awkwardness. We are conditioned from a young age to fill the gap. To keep the conversation going, it makes us uncomfortable.
But the source lists silence as a specific clinical technique. So what is the clinical value of just shutting up?
It creates a space for processing. Think about a patient who is heavily medicated or whose thoughts are racing with anxiety or who is trying to sort through the noise of auditory hallucinations. It takes them longer to formulate a thought and then find the words for it.
So if I ask a deep question like, what was your childhood like? And they don't answer in 2 seconds, and I immediately jump in with, or, we can talk about something else if you want.
You have just interrupted their therapy. You've aborted the process. You've prioritized your own comfort with silence over their need for processing time. You've slammed the door just as they were about to open it.
So silence is actually a form of what the lecture calls psychological presence.
Yeah.
It's a nonverbal way of saying, I have time for you. I am not rushed. I am willing to wait for your thoughts.
Exactly. It's an active, expectant silence. You are observing, you are waiting, you are fully present. It can be incredibly powerful. Sometimes the most important things are said in that space you create.
Okay, let's move to the verbal techniques, the do list. We've got our nonverbals down. We're comfortable with silence. What should we actually be saying?
The heavy hitter, the one every student should master first, is the open-ended question.
Instead of a closed-ended question like, are you sad? Which only allows for a yes or no.
You ask, tell me about what you were feeling today, or how has your mood been this morning? It forces the patient to take the lead. It hands them the narrative.
And then once they start talking, we use reflection and clarification.
Yes, this is how you check that decoding we talked about. This is closing the communication loop. The patient says a long, rambling paragraph, and you say, so, it sounds like you are saying that you're frustrated with your family. Is that right?
You're being a mirror. You're showing them what you heard so they can either confirm it or correct it.
Yes, exactly. It also shows them you're actually listening, which builds trust. Another great one, especially for new students who are nervous, is observation.
This one seems safer.
It is. You don't have to interpret anything. You simply state what you see with your own eyes. I notice you are trembling. I see you're pacing the hallway. You haven't eaten your breakfast.
You aren't saying you look nervous or you must be hungry.
Right, because that's an assumption. Maybe they aren't nervous. Maybe they have a medication side effect called akathisia, which is an intense inner restlessness. Maybe they're not hungry. Maybe their paranoid thoughts are telling them the food is poisoned. By just stating the observation, you invite them to explain the meaning behind it.
Then there's interpretation. This one feels a bit more advanced, a little riskier.
It is. You have to have a good alliance built before you use this one. This is putting into words what the patient is implying but not saying directly. You keep talking about how everyone leaves you. It sounds like you were really scared when your doctor mentioned discharge yesterday.
You're making a connection for them.
You're tentatively making a connection, and you have to be ready to be wrong. You phrase it as a question. Does that sound right to you?
And lastly, broad openings.
These are great. What's on your mind today? Or, as the source says, something like trust means, and you just leave it there. It's an open invitation for the patient to set the entire direction of the conversation.
Okay, now for the juicy part. The part everyone remembers. The don't list.
The landmines.
The non-therapeutic techniques. These are the traps. And honestly, some of these feel so natural and nice to say.
That's why they are traps. They come from a good, kind place, but they have a negative therapeutic effect. The biggest one, the most common one, is false reassurance.
Hang in there. Everything will turn out just fine. Don't worry, it will all work out.
I cringe when I hear it now. It sounds so nice, right? It sounds supportive.
It's what I'd say to my best friend if they were having a bad day.
Of course. But in a hospital, to a person in acute crisis, it's a lie. First of all, you don't know if everything will be fine. You don't have a crystal ball. And by saying it, you are shutting down the patient's distress.
You're essentially saying, your feelings of fear and worry are invalid, so please stop having them because they are making me uncomfortable.
Exactly. You're invalidating their very real feelings. A much better response is to validate the feeling itself. It sounds like you're really worried about the outcome of this. That's understandable. Let's talk about what's worrying you the most.
You enter the feeling with them instead of trying to erase it.
Yes, another huge trap. Agreement. Simply saying, I agree with you. This is so dangerous in psych. If a patient says, the government is spying on me through the TV, and you, trying to be agreeable, say, I agree, you have just validated a delusion. You are now part of the problem, not the solution.
Okay, that's an extreme example. But what if it's not a delusion? What if they say, my mother is the worst person in the world, and you, having met the mother, privately agree?
Still dangerous. Because what happens next week when they make up with their mother? Now you are the enemy who agreed with them that their mother was terrible. You've taken a side.
So you have to remain neutral.
You must remain neutral to allow the patient the autonomy to form their own views and change them over time. A better response is, it sounds like you are very angry with your mother right now. You reflect the feeling, not agree with the content.
Then we have the judgment traps. The first is disapproval.
The source gives a very stark, very extreme example here to make the point. You should be ashamed. How could anyone kill their mother?
That is heavy. But in some settings, like forensic nursing, you might deal with people who have done terrible, socially unacceptable things.
You will, absolutely. And if you judge them, you cannot help them. The moment you express moral disapproval, the therapeutic alliance is shattered. They will shut down and you will never get the truth or be able to facilitate change. Your job is to understand the behavior, not to condone it or condemn it.
And the flip side of that is advice giving. You should get a new job. If I were you, I'd break up with them.
Again, this goes back to what we said earlier. Takes away their power to solve their own problems. Our job is to help them see their options clearly, not to pick an option for them.
And finally, a couple of others. Probing and defensiveness, or challenging.
Probing is pushing for answers the patient isn't ready to give. It's asking why, over and over again. It feels like an interrogation. And defensiveness. Well, the source's example is just perfect. The patient says, I'm a baby, and the nurse challenges them.
If you're a baby, what are you doing in the adult unit?
Right. That's arguing with a delusion or a distorted belief. You will never, ever win an argument with a delusion. All it does is make the patient defensive, dig their heels in, and break their trust in you. You don't challenge the delusion. You focus on the underlying feeling. It must be frightening to feel like a baby.
So we've covered what the nurse does and doesn't do. But the patient isn't just a passive receiver in all this. They are bringing their own armor to the fight.
Yeah.
We need to talk about defense mechanisms.
We can't escape Freud, can we? And for good reason. His ideas on defense mechanisms are still incredibly useful. They are the unconscious ways our ego protects itself from anxiety. They're not good or bad, they just are.
They're survival tools.
Exactly. And the source gives a great list. Spotting these in a patient is like having X-ray vision for a nurse. It lets you see the anxiety hiding underneath the behavior.
Let's run through these because I think the examples are really helpful. First up, the most famous one, denial.
This is just refusing to acknowledge a painful reality. The classic example is the patient with a clear substance abuse problem who says, I don't have a problem with alcohol. I can quit anytime I want. It protects their ego from the painful truth of their addiction.
Next, displacement.
This is the kick the cat phenomenon. I have a terrible, stressful argument with my boss at work. I can't yell at him because I'll get fired. So I go home and yell at my kids or my partner about something small, like the dishes. I've displaced my impulse of anger onto a safer, less threatening target.
We see that all the time. Projection.
This one is huge in patients with paranoia. Projection is taking your own unacceptable feelings or thoughts and pasting them onto someone else. I'm not angry, you're angry at me. Or a person who is having thoughts of cheating on their spouse becomes convinced their spouse is cheating on them. They're projecting their own internal state onto the outside world.
Rationalization.
This is the excuse machine. It's making up logical-sounding excuses to justify unacceptable behavior. I only failed the test because the professor hates me. I only hit him because he provoked me. It's a way to avoid taking responsibility.
Regression.
Going backward developmentally. An adult who is under extreme stress might start using baby talk, or a toilet-trained child might start wetting the bed again after a new sibling is born. They are reverting to an earlier developmental stage where they felt safer and more cared for.
Now, the lecture points out that some defenses are actually mature or healthy. They're adaptive.
Yeah.
Like sublimation.
Yes, sublimation is a fantastic one. It's taking a dark, unacceptable impulse and channeling it into something socially acceptable and even productive. The source example is a person with aggressive impulses who becomes a butcher, or a surgeon, or a boxer. They found a way to express that energy that doesn't hurt anyone.
Altruism.
This is handling your own pain by dedicating yourself to helping others. Someone who loses a child to a drunk driver might start Mothers Against Drunk Driving. They channel their grief into preventing others from suffering the same fate.
Anticipation.
This is dealing with future anxiety by feeling the feelings beforehand in small doses. The example is crying for weeks before your child leaves for college, so that when the actual event happens, it isn't as overwhelming. You've already done some of the emotional work.
Dissociation.
This one is very common with trauma survivors. It's detaching from reality. They might describe a horrific traumatic event without any emotion at all, as if they're writing a shopping list or it happened to someone else. It's a profound survival mechanism to protect the mind during an unbearable experience.
And finally, a classic. Humor.
My personal favorite, joking about a painful or embarrassing situation to lessen the sting. It creates distance and allows you to control the narrative.
So the nurse's job isn't to break down these defenses.
Absolutely not. That can be incredibly damaging. Your job is to spot them and realize this isn't just bad behavior, this is anxiety management. Your real target is the underlying anxiety. If you can help them address the anxiety, the need for the defense lessens.
We have analyzed the patient and their defenses, but Section 6 of the lecture tells us we need to turn the spotlight around and look in the mirror. We need to talk about bias and self-awareness.
You cannot be a therapeutic tool if you don't know your own shape, your own sharp edges. The source puts it very bluntly. Understanding one's own values, beliefs, and biases is critical before you can help others.
It makes a really important distinction between implicit and explicit bias.
Yes, explicit bias is conscious. It's a stereotype or prejudice you are aware you hold. I don't like this particular group of people. You know you think it.
And implicit bias.
Implicit bias is unconscious. It's the automatic associations your brain makes based on years of social conditioning. It's the in-group versus out-group dynamic. We instinctively favor and trust people who look, sound, and think like us. It's a mental shortcut that happens without our conscious permission.
And in healthcare, this has real life or death consequences.
It absolutely does. Patients are incredibly perceptive. If you have an implicit bias against a patient based on their race, their gender identity, their weight, their addiction history, they will feel it.
Even if you don't say anything.
Even if you don't say a word. It comes out in your microexpressions, your tone of voice, how long you spend in their room. They will decode that message of disapproval or disgust, and if they feel judged, the orientation phase fails instantly. You will never build trust. You will never get to the real work.
So what's the antidote? How do we fight an unconscious bias?
The antidote is cultural humility. It's the lifelong process of self-reflection and self-critique. It's constantly checking yourself. Am I reacting to this specific patient in front of me, Or am I reacting to a stereotype I hold about their group? It's being aware that you have blind spots and being willing to learn.
Okay, we're in the home stretch. We've built the alliance. We're communicating therapeutically. We're checking our own bias. Now, how do we actually help people change their self-destructive behaviors? The lecture introduces a powerful technique: motivational interviewing, or MI.
MI is a game changer, especially in addiction and with patients who seem non-compliant. It's a collaborative, patient-centered process designed to engage the patient's own intrinsic motivation for change.
The key concept here seems to be focus on the client's arguments for change, not the nurse's.
This is the absolute core of it. As healthcare providers, we have what's called the righting reflex.
Right.
We see a problem and we want to fix it. We give all of our arguments for why they should change. You need to stop smoking because it's bad for your lungs, it causes cancer, it's expensive.
And the patient just digs in their heels and tunes out.
Of course, no one likes to be lectured. MI completely flips that on its head. You ask, what are some of the not so good things about smoking for you? And they might say, well, it costs a lot of money. Now is their argument. And it's a million times more powerful than yours. You work with that.
So the lecture also says resistance is not a character flaw.
This is huge for nurses. If a patient argues with you or seems resistant, traditional nursing thinking might label them as difficult or non-compliant. MI says no. If you are hitting resistance, it's a signal that you are pushing too hard or using the wrong approach.
So the resistance is a form of feedback for the nurse.
It's a signal to adjust. You roll with the resistance. You don't get into a power struggle. You don't argue. You validate their perspective. It sounds like you aren't quite ready to think about quitting yet, and that's okay. That, paradoxically, makes them more likely to change.
And another principle is to look for and highlight discrepancies.
Yes, you act as a mirror again. So on the one hand, you've told me that being a healthy, active father for your kids is the most important thing in your life. On the other hand, you're smoking a pack a day. Help me understand how those two things fit together for you.
You're not judging, you're just pointing out the gap between their stated values and their current behavior.
And you let them wrestle with that contradiction. The motivation for change comes from them resolving that internal discrepancy, not from you nagging them.
And finally, support self-efficacy. You have to build their confidence.
Absolutely. You use strength-based communication. You remind them of their past successes. You quit for a whole month last year. That's amazing. How did you manage to do that? You build on their wins and remind them that they are capable of change.
Section 8 covers some clinical housekeeping. These are practical tools for the student. The first is the process recording.
The bane of every nursing student's existence. But it's so valuable. It's a written verbatim transcript of your interaction with a patient. You write what you said, what they said, what the nonverbals were, and then you go back and analyze it.
It's like a coach reviewing the game tape with an athlete.
That's exactly what it is. It's where you see your mistakes in black and white. Oh, look, right there, I used false reassurance. Here I missed a huge cue because I was thinking about my next question. Wow, I used silence here and look what happened. You have to review the take to get better at the game.
And the lecture ends by mentioning the transitional relationship model, or TRM.
This circles all the way back to Peplau. It's a modern application of her theory. It extends the therapeutic relationship slightly beyond discharge, often using trained peer support specialists to help bridge that dangerous gap between inpatient and outpatient care.
And it works.
The evidence shows it does. It proves that the relationship is the active ingredient. TRM has been shown to reduce readmission rates, which saves money and, more importantly, improves lives.
So we have covered a massive amount of ground here, from the medication cart to the human connection.
We certainly have.
Let's try to summarize. Key takeaway number 1. The therapeutic alliance, built on Peplau's phases, is the absolute foundation of psychiatric nursing.
Takeaway 2. Your communication skills are not soft skills. They are hard clinical interventions that require practice and precision.
3. Your goal is compassionate empathy, a blend of head and heart that leads to action, not sympathy.
And 4, we must identify defense mechanisms in our patients to understand their anxiety, and we must constantly examine our own biases to ensure we can build a trusting relationship with everyone.
And we use tools like motivational interviewing to empower the patient to save themselves rather than trying to save them.
That's it. You're not the hero of their story. You're the guide.
Dr. Butler's lecture really drives home that this is so much more of an art form than a science.
It is. And like any art, it takes practice. You will be clumsy at first. You will say the wrong thing. You will use false reassurance. but you will get better with every interaction as long as you're willing to reflect on it.
I want to leave our listeners, our nursing students, with a final challenge based on this deep dive. We talked about the power and the terror of silence.
Yes.
So here's the challenge. In your next clinical rotation, or even just in a deep conversation with a friend or family member, try it. Ask a meaningful, open-ended question, and then just wait.
Bite your tongue, count to 10 or even 15 in your head. Don't fill the void. Get comfortable with being uncomfortable.
See what rises to the surface in them and in you when you give people the space to truly decode their own thoughts and process their feelings.
It's where the real work happens, in that space you create.
Thank you for diving deep with us today. Good luck with the care plans, good luck with the pharmacology exams, but most importantly, good luck connecting.
You've got this.
See you next time on The Deep Dive.